Thank you for attending this webinar on international perspectives on estimating glomerular filtration rate equations. My name is Rajivan Selvaratnam, and I'm a clinical chemist here in the beautiful city of Toronto, Ontario, Canada. I'll be your moderator today. We have three prominent speakers today from three different continents to provide three perspectives. Our first speaker will be Professor Amy Carger from the USA. Our second speaker will be Professor Etienne Cavalier from Belgium. And finally, our last speaker will be Dr. Veronica Torres from Brazil. So with that, I'll introduce our first speaker, Professor Amy Carger, who is a member of the Division of Molecular Pathology and Genomics and a faculty investigator at the Advanced Research and Diagnostic Laboratory, or ARDL, at the University of Minnesota. She has multiple roles and research interests, including serving as the director of Central Laboratory for the Chronic Kidney Disease Epidemiology Collaboration, otherwise known as CKD-EPI, which tests biomarkers such as creatinine, cystatin C, beta-2 microglobulin, and beta-trace protein to improve GFR estimating equations. With that, take it over, Amy. Dr. Carver.
Thank you so much for that kind introduction. So I'm excited to speak today to you all about the United States perspective on GFR estimation, and I specifically wanted to give some historical perspective on how we in the US arrived at removing race from our GFR estimating equations, and then talk a little bit about where we are today in terms of what's happening in the United States with estimation of GFR and where I anticipate things going. So my objectives today are to discuss the rationale and development of the new race-free GFR estimating equations in the United States. I'm going to discuss the current state of GFR estimation in the US, and then I'll end with some predictions on the potential impact of the 2024 KDIGO CKD guidelines that were just released this year and how I think that will impact practice in the US. So I want to start first with some history as to how we ended up with these new race-free equations and some of the reasons behind their development in the United States. So first, to go back even farther in terms of why the race coefficient was incorporated to begin with. So the race correction factor first appeared in the modification of diet and renal disease equation that was published in 1999. And at that time, the inclusion of a more racially diverse cohort was lauded as an advance in terms of inclusion for research. And this is because the prior GFR equations that had been derived relied predominantly on white Caucasian populations and were not racially diverse. So the MDR equation had a significant proportion of Black individuals as part of the derivation cohort. Incorporation of a race coefficient into the MDRAD equation was viewed as an attempt to improve and tailor medical care for Black patients. And this was justified by the hypothesis that Black individuals release more creatinine into the blood due to a higher muscle mass on average than their non-Hispanic white counterparts. However, over time, it's been somewhat agreed upon that there's no clear scientific evidence that muscle mass or nutritional status completely explain those differences in serum creatinine concentrations between Black and non-Black individuals. And in fact, there's a commonly cited study in this regard that was conducted in 2008 by Su et al. That looked at differences in body composition, including muscle mass, and also examined nutritional status and determined that those could not explain the differences in serum creatinine between Black and non-Black individuals. So this was one reason to kind of question the use of a race coefficient, because it wasn't really clear what the biological basis was for the observed differences by race. Another issue that has been that was increasingly discussed in the literature is the fact that there are clear disparities in care for Black patients in the US when it comes to kidney disease. So Black Americans have declines in GFR at an earlier age and at a faster annualized rate than non-Hispanic white Americans. Black Americans develop advanced kidney disease at younger ages, with an incidence of end-stage kidney disease about 3 times higher than their non-Hispanic white counterparts. And studies demonstrate that despite this, Black patients are more likely to receive a late referral to nephrology and less likely to be treated with home dialysis therapies. So evidence of more severe disease, but less access to care. Black patients are also less likely to be waitlisted for kidney transplant and are transplanted at lower rates than their non-Hispanic white counterparts. And so it was realized that these disparities are really compounded by, or even one could argue created by, the use of a race correction factor to estimate GFR, which increases the estimated GFR for Black patients for a given creatinine value. So the equations will make a Black patient's eGFR appear better than their non-Black counterparts, and then they're not going to meet some of the cutoffs for obtaining referrals to nephrology or transplant. Another reason why the use of race has been questioned in the United States is this gradual acceptance that race is a subjective social construct and not an objective biological parameter that can be measured or assessed in an objective fashion. So a patient's race can be based on either self-identity, if the person is asked, if the patient is asked, or it may be assigned by a provider who just makes their own assessment based on how the patient appears or assumptions they may have. So this is the first point, is that this either self-identity or the provider's assessment may not accurately reflect an individual's genetic or frankly environmental or social factors. So there's a lot of things that could be affecting kidney disease risk, and the race is not may not accurately reflect genetics or other factors that is listed in the chart. Another point to make is racial self-identity can be influenced by many factors and may change over time. So this can be dependent on a person's family, culture, or geography. I can use myself as an example. I'm biracial. I'm half Korean, half white. When I grew up in Kansas, which for those who aren't familiar with the geography of the US is predominantly Caucasian at the time I grew up, so almost no Asians. I just called myself Asian in that setting because that's what made me different from those around me. Even though I was half Asian, I self-identified as Asian. Later on, when I moved to areas that had a higher predominance of Asian folks, that's when I would identify as biracial. So I have personal experience with this, that depending on where you live and where you're growing up, what side of your family you may identify with, that can affect how you self-identify racially. Another point to make about self-identity is studies have shown that individuals doing at-home ancestry tests, which are quite popular in the US, are more likely to self-identify as multiracial after receiving those results back. So people have changed how they refer to their race in the US based on these at-home tests. Another point to make in the United States is that in 1980, only 6.7% of marriages were interracial. By 2010, 15% were interracial, and that number continues to grow. And from the 2010 to 2020 census in the United States, the number of people who identified with more than one racial group jumped 276%. And again, that number continues to increase. So therefore, race is a very complex thing, and it cannot be objectively defined for individual patients. So in terms of how the equations were ultimately changed and how that movement started, there was really a groundswell of support. So building support for removing race from these equations in the United States. And many attribute the beginnings of this effort actually to medical students who began to openly question the practice of race adjustments during medical school lectures and began to call for the removal of race from eGFR equations. In 2019, JAMA and the Clinical Journal of the American Society of Nephrology published prominent editorials criticizing the use of race in kidney function estimation, since it is a subjective social construct and not an objective biological parameter. And by the end of 2019 and early 2020, there were several prominent academic institutions in the United States that just went ahead and changed the way they reported eGFR to remove the race coefficient. And here's a list of some of those institutions here. By May of 2020, there was, of course, the murder of George Floyd, which was a huge event in the United States. It brought forth heightened cries to enact meaningful change to race-based medicine practices in the US to eliminate healthcare disparities. And following that, there was a June 2020 New England Journal of Medicine article on the harm caused by race-based clinical algorithms, which further highlighted the need for the nephrology community to take action. So ultimately, all of these reasons that I've laid out led to the formation of a task force. The National Kidney Foundation and the American Society of Nephrology announced the formation of this task force in July of 2020 to critically examine the use of race in GFR estimating equations. They set forth to examine every aspect of the inclusion of race in these calculations, recognizing that changes in reporting must consider multiple social and clinical implications, and they resolved to make recommendations based on rigorous science and be transparent to the public, clinicians, laboratorians, and other public health officials in regards to potential long-term implications of the recommendations. And I was privileged, I wasn't on this task force, but I was privileged to serve on one of the expert panels that presented to this task force. I presented specifically on the topic of cystatin C as an alternative biomarker for creatinine. So at the same time that this task force was meeting and conducting and listening to expert panels and thinking about all these issues, in July of 2020, the CKD-EPI research group, led by Dr. Andrew Levy and Dr. Leslie Inker, set forth to reevaluate the existing creatinine-based CKD-EPI equations that had a race correction factor. And what they did is the pooled cohort data used to derive the original race-based creatinine CKD-EPI equations were reanalyzed with the Black and non-Black participants grouped together to derive a single equation. And the new race-free creatinine-based CKD-EPI equations were then validated using a new data set that combined cohort data from the old and then some new studies that they added in. And again, I was involved, as was mentioned in my introduction, as a co-author on this effort. So these two efforts led very nicely to the simultaneous release of the NKF-ASN task force recommendations and these new 2021 CKD-EPI race-free equations. So after 10 months of meetings and deliberations, the task force determined that the best approach moving forward was derivation of a single GFR estimating equation derived from a racially diverse cohort to be used for all patients. The NKF-ASN task force was aware of parallel work by the CKD-EPI research group to derive such an equation because Dr. Inker was part of the, of course, CKD-EPI group and also was a member of the task force. And therefore, CKD-EPI research group expedited their analyses and publication of their new equations, such that the task force final report could directly recommend immediate implementation of their new 2021 CKD-EPI creatinine-based equations. And so both of these were published on the same day, September 23rd, 2021. You can see screenshots of those two articles with the equations published in the New England Journal of Medicine and the task force recommendations in the Journal of the American Society of Nephrology. So just to summarize the recommendations of the task force, their number one recommendation was immediate implementation of the new 2021 creatinine-based CKD-EPI equation, refit without the race variable for all clinical labs in the US. The rationale for this was that it does not include race. It includes diversity in its development, is immediately available to all labs in the US, and has acceptable performance characteristics. The number two recommendation was to facilitate increased routine and timely use of cystatin C, especially to confirm eGFR based on creatinine alone. The rationale here, cystatin C does not have observed differences between race groups, and therefore the cystatin C-based CKD-EPI equation has never had a race parameter. Additional studies have demonstrated that using both to estimate eGFR provides the most accurate estimate. And then lastly, the task force recommended more research on GFR estimation with new endogenous filtration markers and on interventions to eliminate race and ethnic disparities. And to encourage that type of research and to fund it. So their rationale was that newer approaches are needed to generate more accurate, unbiased, and precise approaches to GFR measurement that are not reliant on race and which promote equitable care. So that summarizes how we got to where we are in the United States in terms of removing race. And what I want to talk about now is the current state of GFR estimation in the US. And this is based on two very nicely conducted surveys that I want to go over. So in March of 2022, so this is about 6 months after the release or the publication of those new 2021 equations, the College of American Pathologists sent a survey out to clinical labs regarding awareness and adoption of the new 2021 equations. And these results were published in JAMA in November of 2022. They surveyed US clinical labs and 74% responded. So 3,718 labs responded to the survey, 1,294 did not respond. Of the responding labs, that ends up comprising about 11% of all CLIA certified labs in the US. So that's a pretty good number of labs that are representative of what's going on in the US and that match the geographical distribution of all the CLIA labs in the US. So the survey, the committee that was administering the survey felt that this survey would represent the general practice in the United States well. And what they found was that 76.9% of US laboratories reported they were aware of the new equations. So that's a good sign because it was a relatively new publication. So the vast majority of labs were aware that these new equations existed. And then 30.3% had already adopted the new equation 6 months later. So that's a pretty impressive adoption rate, given how slow things can move sometimes with making changes in clinical laboratories. 58.4% of labs reported that they were unsure as to whether or as to when they would adopt the new equations. And 7.1% said they did not plan to adopt the new 2021 creatinine-based equation. It's important to note at the same time that the survey was sent out, there was an important publication by Miller et al. The National Kidney Foundation Laboratory Engagement Working Group published recommendations for implementing the new 2021 equations. It was called Practical Guidance for Clinical Labs, and this was published in Clinical Chemistry. So it's interesting to me to note that 30% of lab surveys had already implemented it, but this publication was really helpful for the labs that had not done it yet. It had a lot of really very practical steps and advice on how to do it and how to communicate to providers about the change. So the same group, College of American Pathologists, a year later sent a second survey, which provided another update on GFR estimation in the United States. So in March of 2023, the second survey was sent to US and international labs regarding adoption of the new equation. And these results were published in Clinical Chemistry in October of last year. In this case, there were, again, quite a few labs who responded. Of the responding labs, 3,500 of 42 were US labs, so 86% were US labs. And then there were 575 international labs that responded. Of the US labs that responded, now 65.8% reported adoption of the 2021 CKD epicreatinine equation. So that is up from the 30.3% reported a year prior. Important to note for the international respondents that only 36.7% reported adoption of the 2021 CKD epicreatinine equation. And we're going to hear today about the alternative options internationally. Of the 659 US laboratories that had not adopted the new equation, 26.1% reported plans to adopt it prior to the close of 2023. So there were still some labs who just hadn't done it yet, but were planning to adopt the new equation. But the bottom line, in the US, the majority of labs have adopted the new equation, and more are jumping on. So the last section of my talk today, I want to talk a little bit about what I view as the potential impact of the 2024 KDIGO CKD guidelines on practice in the United States. So just a summary of the key recommendations in the 2024 guideline for the evaluation and management of CKD. So the guideline now states for staging of CKD, a GFR estimate based on the combination of creatinine and cystatin C is recommended if cystatin C is available, because it's more accurate to estimate GFR based on the combined equation. And that the combined equation also correlates better with outcomes in the creatinine-only based GFR estimating equation. The combined equation is also recommended when eGFR creatinine is less accurate and the GFR affects clinical decision-making. It's very important to note, and again, we'll hear more today about alternatives, that the guideline does not recommend one specific GFR estimating equation, but rather recommends that the same equation be used for a given geographical or regional area to ensure validity for a given population and consistency with results reporting in that region. So in other words, they don't want a bunch of hospitals in the same city or state to be using different equations. If patients move around in that region, it's good to have consistency with how the regional labs are reporting. However, the guidelines do state that the use of race in GFR estimation should be avoided. So that's consistent with the US position. The 2021 NKF ASN Task Force report recommended facilitating increased routine and timely use of cystatin C. And now the 2024 KDIGO guideline provides concrete recommendations for increased use of cystatin C. So that's one thing they both have in common, this focus on cystatin C. So I did want to talk a little bit about cystatin C use in the United States, since this was mentioned in both the NKF ASN Task Force guidelines and mentioned in the 2024 KDIGO. So one of the issues with cystatin C in the US is it's primarily a reference laboratory test in the United States. There was, again, the College of American Pathologists does a lot of useful surveys. In 2019, They found that only 7% of laboratories surveyed offered cystatin C testing in-house. 93% were sending it out to a reference laboratory. A 2022 CAP survey revealed that only 3.4% of US labs reported the combined creatinine cystatin C equation. Now, granted, this is before the new 2024 KDIGO guidelines, so it'll be interesting to see how this changes. But still, it was the combined equation was not used much in the US back in 2022. And only 8% of labs at that time reported plans to adopt that combined equation. And so therefore, availability of cystatin C being limited to reference labs is a barrier to reporting the combined equation. This makes sense. If you're sending out a cystatin C to a reference lab, you're getting that result much later than the creatinine, so it makes it difficult to report a combined equation in the medical record. There's also going to be differences in the turnaround time, and that's a barrier for providers to use both of those values in real time for clinical decision making if they're getting that creatinine result much prior to the cystatin C. Another barrier in the United States is cost. Currently in the US, cystatin C testing reagents are reported to cost 10 to 20 times more than creatinine reagents. And then also there's some coverage issues, reimbursement issues. Current Medicare coverage determination rules have specific requirements for reimbursement of cystatin C testing that must be met. So you, to be reimbursed, you have to meet the patient has to meet certain clinical criteria. So just to show, though, that cystatin C is becoming more popular in the United States. So this is, again, data provided by the College of American Pathologists that demonstrates year-over-year increases in enrollment in their cystatin C proficiency testing survey, demonstrating a slow increase in the number of clinical laboratories bringing cystatin C testing in-house. And so with the publication of 2024 KDIGO guidelines, its specific recommendations to incorporate cystatin C into GFR estimation, it is anticipated that these numbers will continue to rise, and we will continue to monitor these enrollments. So just in summary, as I close, the US-based American Society of Nephrology and the National Kidney Foundation have recommended immediate implementation of the race-free CKD EPI 2021 creatinine-based equations in the US. And based on the survey data, the recent CAP surveys indicate that the majority of US-based clinical labs have transitioned to this new creatinine equation. And then lastly, increased use of cystatin C for GFR estimation is anticipated in the US, given the recommendations of the NKFASN task force, since cystatin C does not vary by race, and the 2024 KDIGO guidelines on CKD. So that ends my talk. Here are my relevant references, and thank you so much.
Thank you, Amy Conacher, for that wonderful talk. We'll move on to our next speaker. Our second speaker will be Professor Etienne Cavalier, who is currently a professor of clinical chemistry at the University of Liège and head of department of clinical chemistry at the University Hospital of Liège, CHU de Liège. And he is the president of the Royal Belgian Society of Laboratory Medicine and is the chairman of the IFCC IOF Committee for Bone Markers. He is also a member of the board of the European Society for Clinical and Economic Aspects of Osteoporosis, Osteoarthritis, and Musculoskeletal Diseases, and of the Belgian Bone Club. He's a member of the Scientific Advisory Board of the International Osteoporosis Foundation, IOF, and ESCEO, as well as a member of the various societies of clinical chemistry, nephrology, and endocrinology. He has also published more than 350 scientific papers in peer-reviewed journals indexed in PubMed, and has written or contributed to more than 9 chapter books. Professor Cavalier will talk on the European Federation of Laboratory Medicine perspective, or the EFLM perspective, on GFR estimation equations and measurement.
So thank you very much for this kind introduction, Dr. Selvaratnam. So I have the privilege to share with you some points from Europe. To start, of course, with creatinine. Of course, everybody knows creatinine. It's one of the mostly prescribed tests, which is used in clinical practice, as you know, to assess kidney function. It's crucial for estimating GFR. But what is important also is to understand its limitations, which include inaccuracies in early kidney diseases and also influences by muscle age and diet. And this slides really show the relation between GFR and creatinine concentration, and you can see that in the normal reference range, or so-called normal reference ranges of creatinine, you can have in younger individuals GFR for the same concentration of GFR ranging from of creatinine, sorry, ranging from 60 to 120, and it's even worse in older people. So this is an important limitation, but there are also other limitations like analytical limitation, Jaffe method, enzymatic method, which can lead to slightly different results. There are false positives, there are false negatives due to analytical interferences. There are also physiological tubular secretion, 10 to 40% secretion, which is increasing as GFR decrease, and also some evident physiological muscular mass impact on creatinine concentration, as everybody knows. So the question is, should we keep or discard creatinine? Well, honestly, it's one of the most inexpensive tests. It's just a few cents per test, at least for a Jaffe method. And it is one of the most cost-effective markers. It's very specific anyway. And it is very reliable too, with low analytical coefficient variation and traceability to IDMS, which ensure consistent and accurate results. We have the other player, which is cystatin C, which is a small peptide, which is filtered by the glomerulus, reabsorbed and catabolized in the tubules, which has a very nice half-life of 2 hours and minimal variation between genders, ethnicities, and cystatin C is less affected by age compared to creatinine. So why should we use creatinine? What is the clinical use of cystatin C? Sorry. Well, it offers, it should be already mentioned, a more accurate estimation of GFR, especially when it's combined with serum creatinine. It's particularly useful in cases where creatinine is unreliable, as we mentioned, in patients with abnormal muscle mass. And as Dr. Karger mentioned, it's recommended by the 2024 KDIGO guidelines. But still, there are challenges and limitations of the use of cystatin C, one being the cost, very important. As mentioned, it's more expensive, of course, than creatinine testing. It's already mentioned by Dr. Karger, but the limited availability is not yet available in all laboratories, and there are still non-GFR determinants of cystatin C that we have to know, like thyroid function, adiposity, inflammation have been reported to affect levels of cystatin C. But even though cystatin C remains a highly valuable biomarker when it's used correctly. So we have biomarkers, but we also need equations. And among the equations, we have very important things that we all have to keep in mind, and it's often overlooked, is what is the so-called 30% accuracy in GFR estimation. What is this? It's the percentage of estimated GFR values that fall within plus or minus 30% of the measured GFR. And the perfect equation hypothesis, if you had a perfect equation, which does not exist, 100 of the estimated values would be between plus or minus 30% of the measured GFR. In other words, for a measured GFR of 100 milliliter per minute, 100% of the result would be between 70 and 130 milliliters. So that's the best equation that can give you this. Don't make difference between 70 and 130. Of course, for a measured GFR of 30, 100% would be between 29 and 39 milliliters per minute. And just imagine what the impact this can have to the care of the patient. And just like I mentioned, no current equation is perfect in achieving these standards. So equations, we use equation. Which equation should we use? The Cockcroft equation, of course, does not estimate GFR, but creatinine clearance, and should not be used anymore. There's been also widely mentioned about the CKD-AP equation, and I would like the European perspective with the EKFC equation that has been published in Annals of Internal Medicines, which use another concept, which is the rescaling, sorry, of creatinine on the mean of the population which is used for the laboratory. Warning, all these equations, of course, are interesting, but at the population levels. But of course, as clinicians, as lab specialists, we do not deal with population, but we deal with individual patients. And those equations, all those equations present many issues at the individual patient, and no equation is magic. Just look at what I mentioned for the epidemiological point of view. You can have a bias equal to 0, but still the dispersion of the points of the patients around this bias is quite important. It's just like I just calculated before. For GFR at 60 meters, you cannot make a difference for an individual patient between a patient that presents a GFR at 42 or a patient that presents a GFR at 78 meters per minute. So let's compare some equations now that you know this P30 concentration. And I would like to take 3 equations: the EKFC equation, the CKD-EP equation, and the Cockcroft and Gold, just one I presented. And you can see that at best, the best equation here, which is the EKFC in black, achieves a P30 at 90% in GFR above at 60 meters per minute. But when you see that GFR decrease, the P30 also decrease. This is also something that you have to keep in mind. With age, of course, you can see that the EKFC in black again is proposing probably the best result, especially in people lower than 20 years of age. And this is an important point. And with weight, you can see that the P30 equation is around 70 to 75%. With the EKFC equation, you see it's particularly bad with increasing weight, as we know, with the Cockcroft and Gold equation. So it's already mentioned, the so-called race factor is something that we do not really use in Europe. And this is more a debate that we see that's happening in the United States, where it's been already mentioned by Dr. Karger that creatinine levels differ by race between the Black and non-Black American individuals. And despite difference in creatinine, as has been mentioned, the MGFR is consistent across racial group. And of course, has been very nicely explained, this has been considered as discriminatory. So this came been also explained by Dr. Karger to this new creatinine and cystatin B equation that do not use race anymore. But just to let you know that in Europe, I mean, this was no debate, but because we've been publishing several papers showing that this racial factor or so-called racial factor should not be used in Europe and should not be used in people from African ancestry living in Europe, and should neither be used in Africans living in Africa. So this debate was not no matter of anything in Europe and Africa. So there was no debate. The CKD-EP 2009 equation should have been used without the racial factor. So this for those populations. So what about this new race-free equation? Well, from the EFLM, European Federation of Laboratory Medicine, and the European Renal Association have proposed warnings against this equation, because this equation was much more inaccurate in European populations than that. So the point that at this time, we should, the two societies, scientific societies, said that this equation should not be used in Europe. And this is another paper, at least from our group, that has evaluated the performance of creatine-based equation to estimate the GFR in the Black population in Europe, Brazil, and Africa. And we can see that in the conclusion is that in Europe and Africa, the performance of the race-free CKD-EP race-free equation was suboptimal, and that the EKFC equation was the equation that presented the best features and should be used, especially in younger people. So that was interesting, but what about the performance of the EKFC equation in United States? And this is something that is being recently published in Kidney International, where we shown that the EKFC equation presented better results in terms of bias and P30 compared to the CKD-EP equation. And again, this EKFC equation is race-free. This is important because the normalization is based on the population. So it's a population-specific normalization where you divide the serum creatinine of your patient by the median serum creatinine of the local population. And this gives you, anyway, a better accuracy. And you can see that from the paper published in Kidney, the key value that have been obtained in different population living in the United States. What is also interesting in this publication is that you can see that the Q value is quite different in men, in white men and black United States men. But on the other hand, you can see it's exactly the same in a white woman and black woman. So it's not so much a matter of race. There's something that is not understood yet, but it's not. If it was a matter of race, this would also impact women. But this is not the case. Another advantage of the IKFC equation is that it's very broad age applicability. You can see that there is a jump when switching from pediatric equation to adult equations when you switch from the CKD kid to the CKD AP, whereas with the IKFC equation, you can use the equation from the age of 2 to much older age. It also takes into consideration the kidney aging. As you know, the GFR decrease above the 40 years of age, and this is something that is totally modeled in the IKFC equation. And the last equation that's been published by the IKFC group was the equation based on cystatin C, which has the big advantage of being independent of race and sex, and this is the one fully inclusive equation that can be used whatever the gender, the sex of the patient and the race of the patient. So the KDIGO has been mentioned, of course, the 2024, and the one should be measure cystatin C next to creatinine. But in Europe, we proposed something that was similar, but with a more fast reference to measure GFR, because at the end of the day, what we want to know is not especially an evaluation of the GFR, but a true measurement of GFR, and specifically in some particular case where we should not rely on just an estimation as imprecise as I've shown. And this kind of population is, for example, in kidney transplant patients or kidney givings, patients that want to give, subjects that want to give their kidney donors, and in different situations that have been proposed here by the teams of Levy and Stevens already in 2009, and this is also mentioned in the KDIGO 2024. So we should better think of measuring GFR instead maybe of going to more biomarkers. And the IKFC consortium has recently published a very good consensus paper on how we should measure GFR by aerosol clearance, which is easily available, at least in Europe. And then this paper also says that every country should have access to measure the GFR. And I would just like, for those who are interested, to mention two very recent position papers that have been proposed by the EFLM on where we can take position on how we should apply the KDIGO 2024 in Europe, and also some recommendation that we propose for European laboratories, and this is endorsed by the EFLM. And I just like just now to tell you that in Brussels, we will organize the Euromed Lab Symposium from the 18th or 22 of May 2025, where you are mostly welcome. And with this, I would like to thank you for your attention.
Thank you, Dr. Cavalier, for that very interesting perspective. With that, we'll move on to our last and final speaker, who will be Dr. Veronica Torres. Dr. Veronica Torres is a nephrology assistant at St. Paulo State Cancer Institute, University of St. Paulo School of Medicine. She completed her PhD and post-PhD in nephrology at the University of St. Paulo. She also obtained a master's in translational science at Tufts University. So Dr. Veronica Torres will provide a perspective and assessment of GFR from a Brazilian Cancer Institute. Go ahead, Dr. Veronica Torres.
Okay, thank you so very much for the invitation. It's a great pleasure to be today talking to you about the Brazilian perspective on removing race from GFR estimation. I have nothing to disclose, and in my talk today, I'll cover briefly the aspect of race estimation in the Brazilian population, the impact of removing race from GFR estimation on cancer treatment, because it's my area of research, and I think it touches a number of clinical scenarios, and the impact, just briefly, of the KDIGO, the new KDIGO guidelines in cancer treatment. So starting on the topic of race estimation in the Brazilian population, it's much easier to talk after the great presentations from the previous speakers. And as it said, I think that for us in Brazil, it has been always very struggling how to ascertain race, without discussing how, in terms of the nuance between race and ancestry, it has been always challenging for us. Brazil it has a highly mixed population, and so far it's always been struggling for us to ascertain on this. And so it actually was a great relief for us when race was removed from GFR estimation, because precisely it's very hard to ascertain. And as Dr. Carter said in her presentations, I do think that I do support the idea that race itself, either if it's ascertained by someone else, a research group, or the patient itself, is highly subjective to a number of social factors. So this is, I'm sorry for this in Portuguese, it comes directly from the Brazilian Institute of Geography and Statistics. We have a census in Brazil every 10 years. And in 2010, we had here in Brazil, half of the people self-reporting as white, 43% reporting as mixed people, and 8% of people reporting as Black. This census was recently updated last year with 1 year of delay, and we can see that we have an increase in the number of people, of mixed people, that currently respond for the first time for the largest population race in Brazil. We have an increase in the number of people self-reporting as Black, and a decrease of people reporting as white. So as we can see clear here, we had no wave of immigration in Brazil. So that's this increase in on the number of people reporting as Black itself certainly has an impact. We live in Brazil for the last 10 or 20 years, a huge sense of pride in the Black community and taking possession of the Black identity. And I mean, the number of people that are studying that, but so, I mean, in the large scale, it certainly has an impact of much more cultural and I think social aspects than anything else. That said, I mean, I'm not go so much in detail, but we know that also have a large number of studies in terms of ancestry. And so we can see in the middle, this is a study assessing almost 6,000 people in Brazil from different region areas. And we can see here that nearly 4% of the genomic ancestry in Black people in Brazil come from the European background, namely, especially Portuguese and Spanish. So we just to have an idea how, mixed this is. We don't have a large number of studies in Brazil assessing this issue of race in GFR and possible disparities in terms of race, especially because Measure GFR is only available in a few academic centers. It's funded by the public health system, but it's not largely available in terms of the technique itself. It's quite cheap, actually. But so that's basically in 2 or 3 studies. This is, I think, one of the main ones that include Dr. Cavalier mentioned itself. It's a study performed in Rio in an academic hospital, and they compare the Measure GFR performed by the plasma currents of DTA with the serum markers. Creatinine and cystatin C were measured through standardized assays, but creatinine assay was GFR. Here, the problem is that race was determined by the researcher in charge based on a phenotypic appearance, which by itself, we can see that can be highly problematic, and mixed and Black patients were combined. It's also, because easily with all this mix, and considering that certainly we have 5 or 10 shades of mixedness, as Mary speak, these people can easily also be combined as white. So this is, but it's so hard to ascertain that the research, I understand the approach. But the fact is that they had 61 Black patients considered as Black patients in Africa with mostly chronic kidney disease. As you can see here, the mean GFR was around, the measured GFR for the overall population was nearly 50. And they compared the 29 CKD equation with and without the term for race, demonstrating that in overall and as well, especially in the African Brazilian people, bias increase from almost 0 to a number close to 3 ml per minute. And the accuracy, P30, was also worse, decreasing from 75 to 67 when the term for race was used. So suggesting the authors conclude that the term for race actually is associated with worse performance of the CKD equation. This study was mentioned here in the systematic review, together here, the study from Russia with very, very small one study from Veronese, which is, I think that the study itself does not report the data, but they conclude that the accuracy of the term for race actually was worse than without in Black populations outside US. And the study that also Dr. Carvalho mentioned assesses that data from Russia that I mentioned in more detail, but now they included the new CKD in lab equation without race and also IFCC, demonstrating a similar result that both bias and accuracy seems to be in these equations had an accuracy ranging from 73 to 77, 75. It's pretty much similar to each other, but was clearly superior to the equation with the term race, especially in Black patients. So we conducted a study in Brazil, assessing 1,200 patients with solid tumors. We measured the GFR based on the plasma curves of chromidTA. Creatinine cystatin C were measured at Dr. Carvalho's home at the University of Minnesota, both standardized and now with an enzymatic assay for creatinine. And it demonstrated that among the creatinine equations, the Korf-Gaut had the worst accuracy. The CKD equation has a bias creatinine version of -8, somehow overestimating the true GFR. And the combined version with creatinine and cystatin C was almost unbiased with a good accuracy, taking account what Dr. Carvalho mentioned very well in terms of the accuracy is not may work at population level, but individual level, when you have to take important clinical decisions, as we see, it might be problematic. But coming back to the race issue, so we can see we updated this when the CKD equation without race was published, and I'm sorry, I think that's likely covering here, but you can see that the bias comparing the with and without race increased a little bit from -8 to -10. It's not a huge increase. It was statistically practically not different, and the same with accuracy. And the combined version, we see the same thing. We have a small increase in bias, but the accuracy here was quite similar. Our takeaway from this is that actually I have no reason to believe why patients with cancer are different from patients without cancer in Brazil. So, I mean, my takeaway is that removing race, considering all the bias that you have in ascertainment, doesn't cause any harm. I think that all with the difficulties of ascertaining race, I struggle in reporting this among subgroups, but people like to see, so just presenting as this again, this is self-reported race, so it's what patients identify themselves. We can see here that, yes, we have the same trend here in white patients, we have an increase in bias by removing race. We have in Black patients, conversely, there is important decrease on bias and improved accuracy. And for the combined version, the same thing. We have a slightly small increase in bias but agreed in white patients, but an improvement in Black patients. That said, again, this is self-reported race. It might certainly have influenced by a number of factors. So that's why I always prefer to see the overall data. And we also set in sequence both the IFCC equations and the CKD equation 2009 without the term for race, because this is a call from the editors. And you can see here that the IFCC equations perform very well. I think that touches for, I think this population is similar to the KFC original source population, and so that's both the equation creatinine base and cystatin base goes made very well, and there was a small decrease in bias for the term without race, but was not so important. So I think my overall takeaway is that we don't have so much actual data in the Brazilian population, but I think that we stand here considering all the issues in terms of how to ascertain race and the fact that removing seems not to cause any harm. We are on the same page of the CADIL guidelines that we welcome the removal of race. So speaking briefly now in terms of the impact of removing race in terms of cancer treatment, and I think that cancer patients is a group that actually I think that exemplifies several of the challenges that we have in clinical practice. We all patients with chronic disease. We don't have so much data, but this one study performed for the Pittsburgh group in which they assessed Black patients enrolled in phase 1 studies from 1995 to 2010, and they did the number of dose simulations for 10 anti-cancer drugs using the guidelines and labeling approved by the FDA and consensus guidelines, and they compared the 2009 equation with and without race. What they showed is that, overall, there was an important difference between when the term of race was removed of almost 14 ml per minute. There was 18% of discordance in renal eligibility or those recommendations when the term for race and without were compared. There was an important change on the how many drugs were ineligible for therapy. We can see here from changing from 67 to 120% in higher increase, high rates of drugs to be considered ineligible when the term for race was removed. And the same thing, it came along when drugs were recommended to have a dose reduction. So for this number here, that it can go up to 163%. So with that, the authors conclude that removing race from GFR estimation with that is, again, with 2009 equation, might have Black patients with cancer undertreated. And we don't know how the impact of cancer outcomes that might be. The same group with the same data set, they updated now assessing the new 2021 equation of race-free, and they saw that they found pretty much a similar result. Black patients had a mean 10 ml per minute decrease in GFR when the new equation was used without race. And all Black patients actually had a decreased GFR that in this figure on the left, we see the dots in yellow compared to the dots in blue. And that came along to be consistent with different ranges of age and birth surface area. They assessed they developed a logistic model to assess the relative difference in drug eligibility for certain drugs. And you can see, for example, here in the case of cisplatin C, they observed that for Black males of average age and birth surface area, they have 48% higher odds of being ineligible for cisplatin using the new equation race-free, comparing to the equation with race. And conversely, non-Black patients had a 27% lower odds for cisplatin ineligibility. So, and again, that also came across to be the same, to be consistent when in different age cutoffs and birth surface areas. Of remark here, the takeaway I think is that while we don't have further data, we probably it would be wise to encourage both cystatin C and measure GFR for decision making, taking account that these studies do not assess clinical outcomes, so that I think that we are still uncertain, especially in cancer treatment in US. And now talking briefly about the interplay of the new CADIL guidelines and the impact for cancer treatment. as was mentioned, Dr. Cavalli mentioned, creatinine is affected by a number of non-GFR determinants, and which are more frequently observed in patients with cancer. So cancer patients are acknowledged in the KDIGO as a particular population in which the non-GFR determinants of creatinine are more frequently observed, so they encourage the use of cystatin C in cancer patients. This was backed up for recently the largest systematic review assessing nearly 2,500 patients with cancer, also endorsing the use of the combined version creatinine and cystatin C for decision in cancer patients. And also, again, as was mentioned, the KDIGO put an important emphasis on measured GFR, taking into account precisely this. Estimated GFR is not measured GFR, has an important variation in terms of the range that we're accepting, which had made a very important part, especially when treating in situations such as the prescription of chemotherapy. So the KDIGO encourages that measure of GFR to be used for the prescription of chemotherapy scenario, especially for certain drugs as carboplatin, cisplatin, and methotrexate. And to illustrate that, I will briefly touch how this is challenging with a clinical case that a patient that came to my clinic, a 77-year-old white man with bladder cancer, with a history of hypertension and heart failure, that was eligible for carboplatin monodrug. The patient was obese with BMI of 31 and has recently passed the nutrition evaluation in which he had weight loss of 10 kilos in the last 3 months, and a bioimpedance showed the muscle mass deficit. So there was a patient with ongoing loss of muscle mass. His creatinine was 1.17 milligrams per deciliter. In our hospital, we have the standardized assay, but it's GFR. Cystatin C was 1.65. And because of this scenario in obese patients with ongoing weight loss, I ordered a measured GFR, which was 40 ml per meter. This is not standardized by burst surface area, as you see, because of the carboplatin dosing requirement. And we see here a number of estimations. So Cockcroft gout was, we had a measured creatinine clearance in 24 hours, urine, and all creatinine equations overestimated the measured GFR for, different amounts coming from up to 78 for the CKD-EPI to 55 for the KFC. Cystatin C showed a much closer GFR estimation of 37 and between 37 and 40 from the CKD and the KFC equations. The combined version, because of the creatinine component, clearly overestimated measured GFR. So that the dose of carboplatin is given by the Calvary equation, which originally is an equation in which the GFR was set by the measured GFR based on the plasma clearance of chroma DTA, and the prescribed dose was almost 500 milligrams, which is when that came to practice in most cancer centers worldwide. The Cockcroft gout equations that this is used also in my cancer center, and while the dose that the patient should have been received should have been 325. All equations here, creatinine, cystatin C, overestimated this GFR. For some reason, this exam was overlooked by the oncology team, so the patient received that almost 500, and after 4 cycles of chemotherapy, receiving almost 2 grams of carboplatin, which was almost 50% higher than the dose that the patient should have been received if the measure of GFR was taken into account. The patient was admitted with severe neutropenia, with bone marrow aplasia, and died from sepsis in the ICU 3 weeks later in dialysis and with multiple organ dysfunction. So this, again, so that's why we have other guidelines. This is Australian guidelines recently published. Reinforces again the need for us, the nephrology community, to push for measured GFR in situations in which we can see that estimation might be have an impact in clinical practice. and that come along with nutrition status in cancer patients and also in other diseases that is quite diverse and dynamic. So we know that cancer patients have a change in nutrition status over the course of cancer treatment. Almost 4% of the patients have sarcopenia at some point, but there is an increasing number of patients with obese sarcopenia. So there's a hidden sarcopenia, and we know that we can rely on the BMI, but mass index is extremely unreliable in terms of body composition. We didn't have so much data, strong data until recently, and this is our data that we just presented at ASN, and we took a cohort, a number of 465 patients from our cohort of patients with solid tumors, and we did a body composition assessment by CT in a partnership of MassGen in US, and we saw here, and so we assessed the muscle mass and fat mass by CT scan. And we can see here that 1/3 of population had sarcopenia. That stands also in the overall and patients with high BMI. So there is clearly a hidden sarcopenia. And actually here the bias for the CKD equation, without race was -14. The accuracy was 32%. So we really don't know what we're doing, relying on creatinine on these patients. The use of cystatin C clearly reduced bias and improved accuracy to 14 is not ideal, improved somehow, but this is certainly a scenario in which I think that measured FR should be taken into account. Just as a graph here, we can see this is the change of the difference between measured and estimated GFR across the skeletal muscle index, which is the amount of mass the patient has. You can see clearly the huge difference change of creatinine across SMI in a much smaller change on the cystatin C. So I think that in summary, we can say that removing race from GFR estimation seems to be the best approach in the Brazilian population in accordance with the KDIGO guidelines. The impact of removing race from estimation on the treatment of Black patients with cancer, particularly in the US, is not clear. Why robust data is not available, I think that cystatin C and measured GFR might help and should be strongly encouraged. And cystatin C can improve estimation in patients with cancer and support decision making. But I think that we still need to go to measured GFR in situations that the potential markers might be not so accurate. So with that, I'd like to thank you, and I'm happy to respond to any questions.
Thank you, Dr. Veronica Torres, for that interesting context of cancer patients and eGFR equations. So let us move on to the question and answer period. We have a number of questions, and we can start with a few. So one question we have is, cystatin C equations has never seen race difference. However, creatinine-based equations did show a race difference. So why race is not a biological factor rather than social factor? Do you want to tackle that, Amy? And maybe...
Yeah, I can start with that. And I think Veronica also alluded to this as well. So the reason why the thinking about race has shifted to just defining it as a social factor rather than biological is because there's so many things that contribute to how someone either identifies to a race or how someone else may label them as a race. As Veronica mentioned in one of her studies, the researcher was assigning the race just based on someone's appearance, which is, you can imagine, can be problematic because they're basing it likely on skin pigment or things like this and don't actually know the ancestry. So I think what struck me is something Etienne said about how the equations on an individual level present many issues. And this is exactly where race can present a lot of issues when you have an individual patient sitting in front of you. So if you have just two binary categories, Black, non-Black, and you have a patient sitting in front of you, how do you categorize them? There's so many complicated things that go into race. How do you categorize someone who's half Black, 30% Black? How do you categorize someone who doesn't say what their race is and you're just looking at them? Which category do you put them in? And then, in terms of what Veronica said, a lot of her population, it says they're mixed race. If someone just says they're mixed and you don't know what the mix is. So there's so many different factors that play into race and how people call themselves or how other people identify them, that it's not something that can be easily assigned and is not objective. And so I think that's where in the United States we want to move away from that, because it isn't an objective thing at the individual level, and we want to return to using objective parameters. Now, that said, it would be really nice if we understood why these groups have differences in creatinine. I would love it if some researchers would try to actually figure that out, because I think we've been a little bit scientifically lazy in that regard by assigning that difference or attributing it to race when there really is some, reasoning, biological reason, objective reason for that we just don't understand.
Do you have anything to add, Veronica?
No, I'm totally supportive. It's just I think that until one day we had really how to assess ancestry, I'm extremely skeptical about this because of what Amy said. And maybe, of course, I think that also certainly, the perspective on these issues certainly affected by where people are. So I'm sure that that's really critical, for example, for us in Brazil, just to have an idea when we are conducting our study, and when so much people are mixed, when sometimes you ask the patient, how is satisfied? The patient doesn't know to respond. So, oh, doctor, I think that I'm mixed, but what do you think? So it's how when you have a highly mixed population that grows up and live in this mixedness, people really have trouble sometimes to even inside themselves. So it's just, I think that I'm extremely I really think that a certain race is really there's intrinsic bias when you collect this information at an individual level. So until the moment, so I'm exactly what Amy said. I think that until we have, how to assess ancestry actually, and maybe to have objective way, I think it's almost impossible how to remove bias, because there is intrinsic bias when you collect information of race. So that's yes, I totally agree with that in the same direction.
Okay. All right. Another question we have is, can the race-free formula be applied also in Europe? Can we consider the study representative for the European population? Maybe Dr. Cavalier can answer that, and maybe Amy can take on that as well after.
Yes. Well, we do not recommend to use this equation in Europe. Again, this race factor is something that should not be imported in Europe. There's nothing to do with the rarity in Europe, and even nothing to do with the rarity in Africa. What we do recommend in Europe is to use this CKFC equation, because it's been based and validated. I hear some echo here. So it's been validated and established in European populations with the rarity of European populations. It's been validated in different populations, as I mentioned. It's been validated in also in African populations. It's been validated in Africans living in Europe. It's been validated in also United States. And there is no reason why. That's true that I have to take into consideration that this equation is less performing than the 2009 CKD-EPI equation. There is no reason why we by importing something that is not a rarity, we should provide results which are less accurate to our patients. There is, for the first time, we will provide something which is less clinically relevant for our patients, and we should keep to either with the CKD-EPI 2009 without this race factor, and for 10 years even more, we've said that we should not use this factor, and using this factor was giving inaccurate results for Africa, for Europeans from African ancestries, and even worse, it was giving very bad results in Africans living in Africa. And the problem was that if this factor was applied, this had an overestimation of the GFR of the patient, which of course has an impact on the prevention of disease and of CKD. So it was totally detrimental to the population. So again, the two societies, either the European Federation of Laboratory Medicine and the European Renal Association, have warned against using this equation for this reason. And so in Europe, probably the best equation to be used is the EKFC for the reasons that I mentioned. Also because it can be used from the age of 2 until the age of 90. So it's something that can be used for kids, can be used for teenagers, and without having to switch from one equation to the other. And so I do not see any reason why this equation, this race-free equation, should be used in Europe. I mean, I don't see, there is no single reason for me.
Okay. Anyone else want to add to that? Okay. All right.
I can. Oh, sorry. I can just add about the 2009 equation, because I know, as Etienne mentioned, it is still being used by some countries. I will say in the U.S., the view on that, because of this focus on the race issue, is that it's not ideal to use because it was derived in a cohort that specifically excluded Black participants, right? When that equation was derived, they separated out the non-Black from Black. And so that was one of the points of the task force, is they don't agree with use of an equation that's not derived from a diverse cohort. And so based on their view, it would not be appropriate to use to apply the 2009 equation, for example, to Black or African patients, because there were none included in the derivation cohort.
Yeah, just on that note, I did hear that some, I guess, European countries who may be more homogeneous in nature in terms of population are sticking to that 2009 equation without the race coefficient. But on that note, Amy, sorry, did you want to say something, Veronica? Okay. So on that note, Amy, I do wonder, so in your talk, you mentioned that there were some additional new data sets, even though it was refit with the old data, the validation with new data set. Do we have any idea about the diversity of that new data set and to show the accuracy claimed?
Yeah, so that, and I don't remember right off the top of my head, but yeah, that information's in that New England Journal of Medicine paper in terms of the racial and ethnic makeup, because they basically we'd added new studies to make it a larger group of participants in terms of the derivation and validation for that New England Journal of Medicine paper. Okay. But I don't know the numbers off the top of my head.
In terms of diversity, I guess.
Yes. Yeah.
Okay.
But what I had to say is that since by using the Q value, I mean, you somehow get rid of the race. I mean, something's race-free because you compare your results to your own population, and this is something that has nothing to do with race or whatsoever, social construction. It's by itself, by rescaling on your population wherever you are in the world, is something of interest that really, well, it's been done for other microbes, but this really helps to get rid of race and even sex, of course.
Yeah, that is an advantage, the normalization by the Q value of the EKFC equation.
Yeah, I think though, just to present, because just in talking to my American colleagues, I think the challenge that they view with the Q value is right now, at least in those, like the paper looking at US cohorts, they were defined as white Q value, Black Q value, and they, the American nephrology community doesn't like, so if it was just like a geographical Q value that included a diverse white and Black population, but they really want to shy away from, race-based Q values or race-based adjustments in this. This is kind of where the US is at on that. So.
Okay, cool. We'll move on to the next question, which is, should lab implement some limitations of cystatin C to certain conditions and or specific physician groups? So in other words, should you limit cystatin C-based ordering to certain groups, maybe onconephrology, like Dr. Veronica alluded to, or can anyone want to comment on the limitations of cystatin C and appending some of that to the lab reports, or who should be restricted to ordering those cystatin C-based testing?
Yeah, I can comment initially. Oh, go ahead, Veronica.
No, go first.
Yeah, no, I that's an interesting question. I think, certainly there are limitations. Dr. Cavalier showed some in terms of populations where you may not want to measure cystatin C, where there's some non-GFR determinants that were going to affect accuracy. That said, we don't report the limitations for creatinine, although sometimes I feel like that might be helpful. We've certainly had some providers misuse creatinine for eGFR estimation in patients who have amputations and things like that, where they weren't really thinking about the impact due to those patients' lower muscle mass. In terms of limiting ordering, we do that with some expensive tests. So I know that's a consideration given the cost. So I think that would be institution dependent in terms of where your costs are, and if you need to limit ordering due to the cost of the test. We offer cystatin C in-house, and we don't limit the ordering specifically, so that's just our own practice. But I could understand if the cost was a barrier and they wanted to just limit it to nephrologists or to those certain patient populations, like you mentioned, that could be a consideration.
No, yes, I think that, I think that, like in other scenarios, I think it's a clinical decision in terms of, okay, you have, you need to see the patient that you have in front of you. If you have a patient that you're expecting to have, important non-terms of creatinine, so a patient that's MPT, or a patient that's clearly, sarcopenic or cachectic or reporting important weight loss, for example, it's clearly that you probably have, an important non-GFR terms of creatinine. We know that, that non-GFR determinants of statin C are much less understood, clearly, because statin C has a physiological role. Statin C is a byproduct of the muscle metabolism, so it has an interplay with inflammation. So we know that high deposit, smoking, any inflammatory states might affect this cystatin C. So I think that you need to see the patient that you have in front of you. So, for example, that clinical case of mine, clearly cystatin C was almost equal to have measured GFR, far way better than creatinine. So that's clear. Patient was reporting the cancer untreated, recent diagnosed with reporting more than 10 kilos of loss in 3 months. So it's kind of, I would expect it in this scenario, for example, but on the other hand, he's obese. This is the reason why I would expect exactly that. I think that statin might help, but I think that I will not be able to give away measured GFR. So I think that you need to have the patient in front of you. And in terms of ordering, I'm a humble clinician, so what I might say in a dialogue in our hospital that what we have in terms of regulations is that you need some exams in our institution. You need to explain. So we have certain circumstances and you have to justify. So you have to order, for example, you can order 2 vitamin D levels in the window less than 3 months. If you have to, you need to justify. So we order and say, I'm ordering this because of that. And so again, it's a clinical decision or make a case, and the laboratory, you have to say, okay, I agree. So that's I'm think that put limitations tends to sometimes restrict the clinical evaluation. So I kind of assess the patient, the clinical scenario, and to avoid cost, you might kind of have explain why, to have a number of justifications for that.
Mm-hmm. Yeah, I agree with what Dr. Torres says. I mean, you have to look at the patients, and the KDIGO give you some conditions where cystatin C would be of interest. The problem is that it's more, when you look at this, it's more or less all the patients. But again, it's important to take the reality of the patient in front of you to really know what you want to order. And I'm not sure that nephrologists will be the ones that will more benefit from this, because they know this, they're aware that they do not even know any of the equations, if you want my point of view. But still, that maybe for other class of patients or categories of patients, this would be of interest. And then this very nicely shown by Veronica is that sometimes you cannot rely on just a biomarker and then go for the measurement of the GFR. And this is really what we should really promote.
Yes, any patients arrive in my clinic obese, for example, going for chemotherapy, I just kind of, I think it's a very hard scenario for you to any filtration markers. It's just kind of, you might be risking overlooking, hidden sarcopenia, all the issues with high birth surface areas. So I just, in a few scenarios, it's just kind of, if you have available, this is the reason why I'm a strong advocate that we need to push for measured GFR. This is on us to fight for this. Even if we see the first echocardiogram machine 4 years ago, it looked like a wall. And now cardiologists, fight for measure heart function. I think that they changed the field. They fought for. So I think that's on us for fight for measure GFR to be accessible and cheap.
I agree, and we should not forget that we as lab specialists, we have in our hands a reference method, and this is why we don't have so many reference methods in our hands. But having a clearance of IOXOL, iotelematics, this is really a reference method that we can propose that to the patient.
So moving on to the next question. This one's for Amy. Do you think eGFR calculation that includes cystatin C should probably be reported as a separate test? I think Etienne and Bronco can answer this too, and thus can be trended separately. So most of the time, the patient would be monitored by eGFR, current creatinine method, and then maybe annually by the eGFR with cystatin C.
Yeah, no, I completely agree that if it's a combined calculation, it shouldn't be trended with, the creatinine alone or the cystatin C alone. So I would recommend that be its own line in the medical record. Relatedly, and I think there might have been a question or a comment about this later on in the chat, but I've talked about this a little bit, and some argue that it would be confusing, but I do think there is an advantage to having all three numbers, the creatinine only, cystatin C only, and the combined, because then providers could see if there is a big discrepancy between the creatinine only and cystatin C only, and perhaps then recognize that there's some non-GFR determinant affecting one or the other. And in those cases, so if there's something making creatinine-based eGFR very inaccurate, then they can go forward just relying on cystatin C, estimation. If they are all similar, then they can use the combined equation moving forward as the most accurate estimate. Now, I've gotten pushback on this concept because people say, oh, providers won't understand what to do, three numbers, et cetera, et cetera. So, but in my mind, to me, that's the most valuable, is to have all three on three different, reported in three different lines in the medical record.
Yeah, I would just add that there may be some value to that approach, especially in, I think, transplant patients where cystatin C is somewhat more depressed. And I think some studies out of Mayo Clinic have shown that relative to MGFR, as opposed to other patient populations. So, related to this, somebody has also asked, how often do you think creatinine monitoring should be performed in older adults? Example, two to three times per year, similar to A1C. Is there a frequency or recommended frequency as to how often? I guess this is in the context of healthy individuals. How often should you monitor creatinine?
Yeah, Veronica, did you want to say what you do?
No, the KDIGO had, there were a number of societies, including the KDIGO, that reported the frequency of, assessing in the GFR, that it depends on the GFR level. And there's the whole kind of discussion in terms of, the aging kidney, and how you assess if this is CKD itself, or etc. But whatever it is, I think that it depends on your level GFR. There is no specific recommendation that I'm aware of. In specific that you say that in the older patients you have to monitor more frequently. It depends on the GFR. Mm-hmm. So if you have a patient with elder patients with CKD, depending on the GFR level, you are advised to follow up this once, 2 or 3 times a year, depending on the GFR level. So there's no specific recommendation on, just by the fact that the patient is elderly, that you base this frequency. That I'm aware of, but let me see what.
Yeah, I agree. Also, basically, if you change the treatment in CKD patients to see, you want to see the impact on treatment on the renal function. But yeah, I agree with you that this is really depending on the patient and yeah.
And I will say one advantage of creatinine, of course, is that it's in metabolic panels. So a lot of people have a lot of values because they get panels measured for other reasons. So that is an advantage of creatinine over cystatin C, for example, which typically wouldn't be measured in, it wouldn't be measured in routine situations.
Yeah. Okay. So related to that, I was just wondering, when it comes to we're looking at functional assessment through creatinine. What about microalbumin? And that's a question that was posed as well. Should you be also measuring microalbumin in all patients? And that was a question posed as well.
Yeah, this is a very important marker of kidney damage. And this role really has been again emphasized in the KDIGO 2024, and this should be really part of the basal evaluation of kidney function. Is one of the two most important player with the estimation of GFR. Is really this microalbumin that has to be corrected with creatine. So we're talking the ACR. So I believe that this test should be much more prescribed than what it is in reality, because maybe that's it needs urine, of course, but still it can be done. It can be done at any time of the day. Of course, if there is positive, that should be controlled again, and there are also a frequency that should be so the patients with anemia should be monitored. So this is really an important and again a very cheap marker, which is for me, at least in my practice, much more prescribed than what it is in reality.
Yeah, you do need both to really diagnose a stage of chronic kidney disease.
Yeah.
Yes.
Yeah, and just to add, in the U.S., I mean, it's definitely underutilized. There was a nice study done, published a couple years ago in 2023, that looked at about 200,000 patients with diabetes and hypertension, so significant risk factors for CKD. And I think only like 17 or 18% had urine albumin measured over a 2-year period. So it's a very underutilized test here in the U.S. and something we're trying to emphasize more and more.
Yeah, agreed.
One question I had for all of you was, the KDIGO 2024 guideline also mentions the kidney risk equations or kidney failure risk equations. Have any of you implemented that, or do you have any thoughts on those?
Yeah. I mean, I in our template, in our hospital, we have it for all patients. I think that I think again, there's a model developed. I think that is just kind of, again, you have to, but I think that it helps you inform the patient somehow, and to understand when you calculate the risk of dialysis 2%, 5% in 2 or 5 years is kind of somehow reassuring, and you can plan your strategies of, how in terms of both in terms of strategies to prevent CKD progression, and also how to prepare patients for future treatments such as dialysis and kidney transplantation. So I think that it helps in clinical practice to inform how somehow, again, putting in place that it's a model, but I think that it helps you to kind of put in a frame where you stand a little bit, and helps you a little bit to inform a little bit the patient in terms of where it is. I don't know, is this the question that or
Yeah, I mean, do you automatically calculate kidney failure risk equations, I guess, since it's now mentioned in the guidelines? I know at least here we haven't hugely adopted it, but some community reference labs do make use of it.
We're in the process of implementing it on the protocols also. But
the question is, would it be applicable to transplant patients as well? Okay, we'll move on to the next question. What formula to use for pediatric population to implement in a lab that only uses CKD EPI 2009 in African country?
Well, in the U.S., there is the Schwartz equation, and I know Etienne was saying that the EKFC applies to children. So in the U.S., we have separate equations for adults, CKD EPI for adults, and then Schwartz equation for pediatric patients. Yeah.
Well, we had the FAST equation that has been replaced by the EKFC, and of course this is really when we make the EFLM survey in 2022, I was really surprised to see that very few labs really took care of children. I mean, of estimating equation, estimating GFR in children. I mean, this is when many labs do not propose anything for kids, and when they propose the equation, it's a very low percentage of laboratories, even if they provide cystatin C, they do not provide any equation to estimate GFR. So that this is something really that we propose in the recommendation of the on the papers. One of the two that I mentioned of the 2022 based on the 2022 survey is that we should do something for kids and propose an estimation of GFR when creatine or cystatin C are requested by pediatricians or nephrologists, pediatricians. This is clearly, I was totally shocked to see that it was clearly lacking in many labs in Europe. That they just provide a number and that's it. Whereas
no, I think that's an issue here in the U.S. too. I will know from our perspective, we at our site, even though I direct a children's hospital, our IT folks don't want to report it because we don't often have a height that goes along with that creatinine. So for them, it was more of an issue of not wanting to be inaccurate if they pulled an old height because that equation has the patient's height. And so it was really that logistical issue. So unfortunately, our pediatric providers have to go to the website online to enter it into the calculator. So it is more difficult for them.
Yeah, I understand. So that's why that's why we propose also one of the big reason why we propose also the KFC is that you can, it's the same, exactly the same. So you've got your Q value based on your population, and it's so exactly working the same way. So you can propose from the age of 2, and this will solve this issue really.
We have
doctors, unfortunately, we are out of time.
yes.
So
Okay. So thank you all. Yeah, we will answer much of the questions via email. We do have some questions left. With that, I'll make some concluding remarks. So thank you for attending to this webinar, and thank you, Professor Carger, Professor Cavalier, Professor Torres da Costa de Silva, for your interesting presentations that provided such valuable information on the topic we discussed. And of course, thanks to Dr. Faris Tayi for coordinating this webinar, and to the IFCC for offering this tool for the e-learning. Please remember that if there are unanswered questions, they will be replied by email to those who posed the question. The certificate of participation will be provided at the end of the webinar after a few questions. At the end of the questions, please click to show my scores at the end of the page and get your certificate. And last, the on-demand content of this webinar will be available in short, and you will be informed via email. There will soon be other IFCC free webinars, and they will be announced via IFCC communication channels, email, website, IFCC social media. Thank you and goodbye.
Thank you very much.
Thank you, everyone.
Bye-bye.